Hello and welcome to Sensei podcast. This is Manos Brilakis discussing with leaders in the field of CTO and complex PCI. Sensei means teacher or master in Japanese. The goal of the Sensei podcast is to help you learn and improve in CTO and complex PCI so that you can become the best that you can be and offer your patients the best possible results. Hello everyone and welcome to Sensei Podcast. It is my great pleasure to introduce Dr. Ajay Kirtane from Columbia University, where he's professor of medicine, and actually he's the founder of the CHIP principle and one of the teachers of this in many meetings and in person around the world. So Ajay, welcome to Sensei Podcast.
Well, thanks so much for having me, Manos. I think this is a great idea to do these podcasts. Really happy to be on. I will correct you in the sense that I'm not the founder. The reality is, and maybe this is something we can start with, is it was a meeting that was in Jeff Moses' office where the kind of acronym came up. And a lot of the CHIP concept was founded on Jeff's practice, which was one which represented a lot of these referral patients turned down without other options. And we were trying to quantify that or codify it in a way, and that's how these things came about. And so I gotta credit Dr. Moses, Dr. Leon, Jeff and Marty, mentors of mine, for this as well.
But you still wrote the paper, you were the first author of the circulation paper, so a lot of work happened on you. So again, thanks for spearheading this area, which now is well accepted. There's a CHIP CTO India happening this month, and it's just common practice around the world. So how did this start for you? How did this CHIP concept, learning to do complex, how did that, I know you've been surrounded by excellent people, obviously, but how did this happen for you? Was it a passion? Did it happen along the way?
I trained at a bunch of different places. I think throughout my career, whether it's from medical school to residency, fellowship, and beyond, I always found that getting new perspectives was something that I definitely enjoyed. I also found what I really liked about interventional cardiology was that while I was always involved in research, it's still such a clinically based field. And as a proceduralist, it's very technical. You're in the cases and doing those cases. But if you only focus on the case that you're doing with your hands at that time, you're missing the boat because there's a patient on the table. It's not a lesion on the table. It's not a calcified lesion or a CTO on the table. It's a patient that has those things. And I think that's one of the nice things about having trained in internal medicine as opposed to straight surgery is that we're used to taking care of patients on the outside as well. And so these issues of how patients make it to the lab, how some don't make it to the lab, how they make it to other labs that may be better equipped or less equipped than what we have, I think that all of those things were observations that I guess I made throughout my training at different places as well. So when I came to Columbia, and having seen, the practice that Jeff was involved in and that all of us were involved in, we kind of inherently understood that it wasn't that every lesion needed to be stented, for sure. There were a lot of people coming to the cath lab that, didn't even need to be in the cath lab, not in our lab necessarily, but just throughout the US. And I think that's gotten away to a large extent now, but at that time that existed. But there were also a lot of people that you would just remark to yourself and say, oh my gosh, how did this person not make it to me till now? In fact, the reason they made it to me was because a friend knew a friend who knew a doctor who could then send them to us. And it was this idea of this sort of disproportionate care that sort of became manifest. I will also say strongly that it was in the backdrop of a lot of criticism of our field for those unnecessary type procedures. And we noticed that, yes, at the same time there were unnecessary or overuse type of procedures going on, there was this clear need for patients that weren't getting to see us at the same time. And we thought that that was a much better way to focus individuals and interventionalists, referrings, et cetera, on how we can actually help people as opposed to this negative focus on, we're really hurting people. Of course, those things are important, but there were a lot of other initiatives afoot already to sort of limit those types of cases that were going on.
Perfect. Yeah, thanks, Ajay. And obviously it's been a journey and a trip. And apart from selecting who is benefiting from this is one thing that is a steep learning curve, I'm sure. But in terms of actually doing the procedure, there's also a steep learning curve there as well. And obviously you've been exposed to excellent operators from top notch. But how does that learn? Because having someone next to you helps, but you still have to do it yourself.
Absolutely. And so for me, I trained in a cath lab that we were very facile in things like, rotational atherectomy, but we did very little imaging. When I came to Columbia, imaging was used not in the number of cases it's used in now, but it was used in a lot of cases. And immediately I recognized, wow, I have to learn this. I've always been somebody that wants to learn new skills. And I will tell you from the beginning, both Jeff and Marty really set the standard for trying to broaden your skills and learn new things and test them out. And if some may work, some may not work. Jeff, some people remark on, how is he still doing what he's doing after all the decades he's been in the field? I think it's because he's just super young at heart. He's really willing to try new things, and that excites him. And similarly, Marty, every year at TCT, he's like, what can we do differently? So that was sort of the environment that I was in. I felt that structural heart disease was not something I was going to do. That was largely because one of my good friends and colleagues, Sushil Kadali, was leading the structural program. So it was really going to be focused on coronary and or peripheral. And so for me, at that time, CTO was rising. We were able to recruit, a good friend, Dimitri Karmpaliotis, to come. I trained with him, and I just started doing cases with Dimitri. And there was no ego. There was no sort of feeling I know what I'm doing and therefore I can't learn from him. This was immediately, you could see that he had skills that none of us had. And why would you not try to learn from those skills? And so it was that kind of environment, and that's how I kind of got into it.
And what did you find the most difficult thing to learn? Was it retrograde, ADR, support? Is there a specific skill or holding the guide? What was the thing that you found most difficult to learn and to teach to your fellows?
I think in the individual time you're doing it, probably the hardest skill I thought were two things. One is spinning the microcatheter to get it through collaterals. We tell our fellows all the time, this is not something you're going to pick up right away. It's very frustrating because they sort of try, it doesn't work, and then one of us takes over and it's like, and the microcatheter goes down. So that was probably one skill that I would remember that way. Retrograde obviously is one that it feels somewhat random, although I will tell you that even really good operators, when you see them, it still looks like they struggle sometimes when they shouldn't. So I don't think that's inherently the skill part. I think it's just the type of collaterals that we have. But I think those would be the technical ones. I think, but just looking longitudinally over time, what I feel like I've learned the most is the experience of picking the cases right and trying to understand when we're going to have issues, when we're not going to have issues, but always being humbled that even though you think you finally have it right and figured out when the patient needs support, when they don't, when you're going to do it or not, something random will still happen, and either you'll succeed in a way that you really shouldn't have, or you'll unfortunately have a complication when you thought there was no way, or you thought that you had mitigated against it.
Perfect, absolutely, and it keeps us humble and down to earth, I guess, all of us. Now, when it comes to selecting fellows, you get a lot of people who want to train with you. Are there any criteria you use? Can you tell this person is going to be phenomenal? How do you select these people, and what should they do to get into Columbia, one of the best programs?
That's a great question. I think the hardest thing, especially, and we've had discussions with some of our European colleagues about this, is that the U.S. style interviewing is softballs. It's basically, tell us the 5-year career or the 3-year career or whatever. And the UK style, for instance, is you have a patient with aortic stenosis who has a gradient of whatever. Tell me exactly how you would do the procedure, what catheters, et cetera, would you do to do it. And I think if we did that with the typical U.S. applicant, we'd probably be looked at like we had, 5 heads. So that's not something we typically do. So it's hard to evaluate someone's technical skills. We don't do the management consulting style interviews where we give them, problems to solve and we watch their hands doing it and all of that type of stuff. But I honestly think for most interventionalists, it's really not the technical thing. There are, of course, people who are technically, above and beyond. Those people you'll hear about because somebody will write a letter saying, I've never seen somebody, that coordinated or using their hands. But everything else is really just a mentality. And for me, the best mentality is a humble one. It's a mentality where people are willing to learn. And it's not one where there's overconfidence projected. Because to me, the most dangerous fellow, trainee, attending, or whoever is somebody who does not know their limitations. And I'd much rather have somebody tentative who we can teach to be less tentative with skills than the opposite.
Perfect. And then when it comes to teaching, obviously you saw them on the spot, there are books, I know you're active on social media. What do you think is the best way to learn? There's the meetings, there's CTO Plus, there's TCT, all these meetings that have a hands-on component. What is the best way you think for someone to learn to do these cases, for the fellows specifically, the early career people?
Well, great question. And actually, my social media has changed a little bit, but that's, I think, one of the things I would want to comment about. I would be very, very reluctant to tell people to spend a lot of time on social media like Twitter or things like that. And the reason for that is because there's a huge bias in terms of what's presented versus what's not. So if someone presents a case, for instance, on Twitter and you see it, that might be their best case in the past 6 months. And that's why they're tweeting about it. You don't see the 99% of other cases that they didn't tweet about. And so there's a huge skew in terms of numerator versus denominator and what people can do, what they should do or otherwise, number one. Number two, you don't know necessarily about the comments, what the experience level is, what the practice patterns are, and the environment is that other people practice in that would influence those comments. And again, it's only a short snippet of 280 characters. If you were to go to a meeting and talk to somebody about it, you'd hear a lot more nuance, even from the same commentators, because you have more time to be able to do it. So my feeling is you have to take some reputed operators. I don't mean to pitch you, Manos, but like your YouTube videos, as everybody knows, I mean, you're established, you're a good teacher, you're going to do it in a reasonable way. Those are things that I would encourage people to do. And then finally, remember, there's limited time in the day. So if you just spend all your time watching YouTube videos of live cases from the same site over and over again, well, you're only going to learn a snippet of the way those people practice. So I do think meetings are super important, case-based sessions, and try to talk to people who are less authoritative and more tell you the limitations of what they're doing as well. Those people inherently are going to give you a more balanced viewpoint.
Absolutely. And then how do you deal with the Cath lab and the staff? Do you have special sessions for them? And would you advise people to take this on if they don't have a lab that has the capacity, the heart failure team as you do, to support potential complications? Well,
I mean, there's definitely no I in CHIP. There is an I in CHIP, but there's not. It doesn't work that way. You have to do it as a team. And in fact, if you're going to start taking on more high risk or complex cases up front, by definition, the adverse outcomes are going to go up just because the patients are sicker. And so if you don't have a fully orchestrated plan where you're educating staff, whether you're talking to the CCU, you're talking to administration about utilization and complications and those types of things, these programs are bound to fail. And so I really think it's important to enlist not only your own colleague, it's often helpful to do these cases with a partner because they're much higher risk cases, and also you can shoot ideas off each other, you give each other moral support, but you really have to get everybody involved. And for those who are looking to start this out anew, it's a great resource to talk to people that have done it before because they'll give you all of these tips and avoid making the pitfalls that could have been made or some of us have made in the past.
So, and just specifically for you, how do you keep up? You have a very demanding clinical practice. You have all the research component. You have all the educational component. So how do you keep it up? And are there things you exercise? How do you keep things functioning and motivated to do all these things?
Well, first, I think you can't bite off more than you can chew. And so I said up front that I didn't do structural as a result. You can't do everything. So you focus in a certain way. You also don't have the ego to say that I have to do everything. So we, as I said, we recruited Dimitri. He's moved on elsewhere, and recently we recruited Margaret McIntaggart, and she is the designated person for these things. I don't have, an ego to say that I need to do these types of cases. I want the program to grow, and so that's the sort of philosophy that you need to have. I think in terms of keeping up otherwise, again, there's limited time in the day. So for me, getting off of Twitter was like the best thing I ever did. I read more long form now. I can read more manuscripts rather than being overloaded with all this information that's being fed to me. I actually think that these algorithms that feed stuff to you are worse for you because they make you feel like you have to look at everything as opposed to thinking programmatically and strategically and saying, today I want to learn how to spin a microcatheter. I'm going to go and look at Manos' video of how to do that. I got that done. Tomorrow, I want to learn how to surf retrogrades. I'm going to go do it this way. So I think that sort of strategic-based way of learning is super important, and it's something that I'm happy to have been re-engaged in more recently. You mentioned exercise. I think you definitely have to, keep fit. Your back is going to hurt with these cases. There are a variety of products that can be helpful in that regard as well that are coming out. That's exciting to see. But it's really important to be fit and to also have a mind outside of medicine.
So how do you keep your excitement right now? What are the things that excite you the most at this particular time?
Look, I don't want to sound too philosophical because I just turned 50 and my kids are out of the house and that kind of thing.
Congratulations.
I think, thank you. I think the training aspects of what we do keeps me excited. I think you always have to be thinking about something new. So a lot of the upstream workup, things like CT, plaque, those are exciting concepts. It may seem dull to interventionalists to talk about pharmacology, but one of the interesting things that we found is that for people coming into our hospital with complex PCI, 40% of them didn't have their lipids at goal. They're coming in for a CTO. We know they have chronic disease or a left main or something like that. And their LDL was, and by the way, we used a cut point of 70, was above 70. So these are easy things that we can fix, and they're going to make public health differences in addition to the technical things that we do within the lab. I am excited, as I said, about some of the radiation protection and orthopedic protection issues as well.
So Ajay, what is your favorite book and your favorite movie?
The favorite book is a tough one. It's kind of what I happen to be reading at the time. Movie-wise, I'll tell you that there are a few that I really, if it's on TV, like I will watch. And, A Few Good Men is sort of a standard one of those. I actually will tell you that I really like Shang-Chi and the Legend of the Ten Rings. It had special resonance for me, not because I'm a Marvel fan, but I'll tell you, as an Asian American in the U.S., to see an Asian American typecast in a lead role with not just the stereotypes that were there, some of the humor with the stereotypes was there, but he was legitimately a lead role. Actually meant a lot to me. There's a lot of resonance to it. Hearing him go, for instance, to a karaoke bar and sing an American song as two Asian people singing it. It really was a big thing for Asian Americans, I think, and a lot of people may not even realize that. So for me, it was really nice to see. Actually, similarly, there was a movie called Yesterday, which was done in the UK with a Indian or South Asian lead role playing guitar and legitimately being in the lead role. These little things make a big difference for me. I think growing up Indian American here in the U.S., we sort of, we're used to seeing Apu from The Simpsons or caricatures of our parents and our personalities. These are actually real people who you can look up to, and that meant a lot as well.
Perfect. What are you most proud of?
I think I'm most proud of the legacy that I've actually been able to hopefully uphold in the Columbia Cath Lab. That right now, this is on a professional basis. Clearly, in my life, I'm most proud of my family, my kids, and all that other stuff. But I think that in my work family, this was not an easy job to take on. We're talking about a cath lab with Marty, Jeff, and the excellence and outstanding nature of what they've established. Not only that, the people that have been in the cath lab, et cetera. And, when you sort of have to inherit that role, for instance, as a cath lab director, you wonder and you think around and you're like, why me? And I think the reason why me oftentimes is because I do think I can get along with almost every personality type. The conversations are not always easy, but I think that people know I'm fair. People know what I stand for and my ethics and my morals. A lot of that, by the way, was not because of me. It's because of my parents and what they imbued in me. And so to be able to do that, but yet at the same time to make sure that we're current, we're relevant, we're doing the right things, and then training the right people. I knew those things were going to be tough, and I didn't know how I'd be able to do it. But I feel like we've been successful in being able to do it. So I'm super excited about a lot of our junior attendings. I'm super excited that we were able to recruit Margaret, for instance, who's just an amazing person, outstanding in the lab and research-wise and in so many other ways. And I'm also really excited that we're still able to keep things interesting for Jeff, because he's just such an amazing person. And I call him the godfather of CHIP in this whole field. And the fact that he's around, he can teach me still every day, not just cardiology, but about family, about politics and everything else. It's just an amazing environment to be in. So I think that's probably the thing I'm most proud of. Obviously, this is all because of people like Marty and our division chief who foster this environment and have given me the opportunity to be able to do this. So there's so many people along the way who I have to thank for it.
Yeah, I mean, clearly it's an amazing feat, and being able to juggle all these different roles. I mean, it clearly takes a lot of mental capacity and organization. So it's amazing. But what is exciting for you? What is the next thing for you?
Next thing is, well, I've been involved a lot in renal denervation. That's totally outside the chip space. What I do find cool is these balloon pulmonary angioplasty cases. So they have nothing, you could say they don't have anything to do with CTOs. But I actually learned about it again through a meeting. I was at a meeting and Rajiv Gulati at the Hartzler meeting showed that he was doing these types of cases. And I had at the time been doing these CTO cases with Dimitri, and I kind of immediately thought, hey, this looks like kind of a CTO without a retrograde. Obviously, the complication risk is different because there's a higher rate of perforation, and you can't just tap the pericardium. So how can we do these cases safely? What kind of equipment do we need? And so around the same time, about 4 months after that, one of our adult congenital interventionalists, who's actually a pediatric doc, came to me and said we had this patient with CTEPH and had pressures in the 120s, almost systemic, but multiple clots, and he was going to think of doing a balloon pulmonary angioplasty, but he said he's only used to using balloons like 12 millimeters and above, and he thought that the vessels that we were going to treat were going to be a lot smaller. So what did I think? And I remember hearing Rajiv's talk. I remembered that this could be possible. I obviously looked up my research, and I'm one of those people who, like, distal radial, there are some people who said, oh yeah, I see this on Twitter, I'm going to start doing it. That's not how I work. I looked at the anatomy books, I talked to hand surgeons, we went through this whole thing to be sure it's safe. So same thing. But what I did think is it might be useful to use microcatheters. It might be useful to use trapping balloons or trap liners and that sort of thing in the cases. And so obviously you have to be conscious of cost, but that's kind of what we've started doing. And it turns out that I view these as like CTO lights. They're definitely easier to cross than normal CTOs. But as I said, there's no retrograde, so you have to be sort of cognizant of those risk benefits. And for me, one of the things that I've been pretty happy about with my practice is I think I have a pretty sound appreciation for that risk-benefit balance when you're pushing the envelope too far or too little. And so as a result, we've been doing these types of cases, and not on everybody. It's people who are inoperable for PTE or those who've already had a PTE done. But the outcomes have been, really good. We do need randomized data in this space, but these are obviously high risk referral populations at present. So I'm kind of excited by it.
So always keep on learning. It looks like you never lose your enthusiasm for learning new areas and new fields, which I guess is a characteristic of people doing this area in general.
Yeah, just like you.
Well, there's something exciting. That's why the whole thing is about learning. How can you make this more effective and more motivated? So if you had to give your advice to people who want to do this, people come to you and say, look, I want to be like you, like Dr. Kirtane, very good, very solid, being able to balance all these things. What would you advise them to do?
Well, number one, keep it fresh. Number two, don't be only in the lab. A lot of the joy and satisfaction of what we do is by being able to see patients outside the cath lab as well, before, after, taking care of their parents, their relatives, etc. Number three, don't disparage general cardiology. I actually think that still practicing general cardiology in the outpatient setting really, really enables you to understand your referring physicians and understand where your patients are coming from. And then the final thing is always make time for family. That also keeps you grounded in terms of what you do. Now, somebody who's listening to the Sensei podcast may say, well, why the heck did he not talk about the technical stuff in the lab? Those things are a given. I think that they're super interesting and exciting, and I always liked using my hands to do stuff. And so for me, those things are obviously a given for somebody who's going to listen to this. So the reason I mentioned the other things is because there may be less people mentioning them. Final point I'll mention is I like playing music. Music is a huge part of my life in many ways, and I do find that I play the guitar. That the left hand, the finger stuff, and what I do with the tui, as well as the ability to transmit the right hand to the left hand, technically in terms of what I do, has always been adaptive. I never really thought about it as much until more recently, but the more I think about it, I actually kind of understand now that some of those things that come innately to me because I play may not be so easy to teach to other people, or you have to be conscious about how you teach it to folks that don't necessarily have the ability to translate what they're doing with their right hand to their left hand at the same time.
Absolutely. I think that's the one we haven't heard before, and probably I wouldn't advise them to start the guitar now if you're going to be a cheap operator, but absolutely translates.
Hey, everybody wants to be a rock star, right?
There you go. Fits very well. Well, Ajay, thank you so much. This was phenomenal. Thanks for taking the time. Thanks for everything you do for the field, and excited to keep on working with you.
No, likewise, Manos. The admiration is mutual. So thanks for doing this for everybody, and I really look forward to looking at some of the other episodes.
Great. Thank you so much. Thank you for listening to the Sensei podcast.